So there are new guidelines available since this year, the EFSUMB updates 2020. So there's a couple of recommendations, and I summarize the recommendations. So if we look at the first three recommendations, the key message is ultrasound is safe. It's safe in the adult population, it's safe in the pediatric population, and it's also safe for intercavity use. So the fourth recommendation will be CEUS should be recommended in patients with inconclusive findings either at CT or MRI. And it should be also used as one of the first modality if a patient has got renal insufficiency. When I prepare this talk, I thought it will be a little boring if I only look at the paper and show you so much. So I thought it would be great to combine these strengths directly as an image. Therefore, the question is, can your device do this? I think you need a special hardware and software on your system. Otherwise, you will not be able to do this directly on your system. But before you start the contrast-enhanced ultrasound examination, there should be a systematic training, and you should start with grayscale and color level before you use the contrast agent. So if you look at the bubble size is similar like a red blood cell. The first generation was filled with air. Nowadays, it's filled with gas. All bubbles have a shell, either palmitin shell, albumin, or lipid shell. And the major difference in comparison to CT or MRI contrast is that we are speaking about a pure blood flow contrast agent. How it's working? So you see the bubbles, the ultrasound wave compress and decompress the bubble, and the bubble works as a backscatter. So if you have got the proper software available on your system, you see the oscillation of a single bubble. If you won't have this software on your system and try it, you will see immediately that the bubbles will destroy and it will be no help for diagnostics. Important is that these contrast agents have got no influence on renal and thyroid function, so there is no need to have a lab. But all patients have to give an informed consent that they agree for this examination. When we look at these new guidelines in comparison what was in the past guidelines, we only speak about three phases: arterial phase, portovenous phase, and venous phase. But now we also add the post-vascular phase, but this is specialized to sinusoid, which is only, I think, in Norway available in Europe, but it's also used in Korea and Japan. But in Europe, most of all, we focus only on these three phases. In this talk, I will speak about a couple of benign and also malignant liver lesion, as we've seen it here. So starting with the benign liver lesion. So remember, these are the four phases I show you before. So the arterial phase, we see a perineural enhancement, and the portovenous phase, there's a partial or complete centripetal filling of the hemangioma. And in the venous phase, it's incomplete or complete enhancement. By looking at the post-vascular phase, where we have a special contrast agent, it's either or slightly hyperenhancing. So the most important phases for us are these three phases. So if you look at the grayscale, you see this hyperenhancing area there. So you see, if we inject contrast, these nodules which show up there, and over time these nodules are growing until the complete lesion is filled. Sometimes hemangiomas could have thrombotic changes inside. That's the reason why they're not completely filled, but they have no washout in the late phase. So we see typically this very bright organic lesion here. It has only some peripheral vessels. There are no vessels inside of this lesion. The next step, we look at the contrast setting. So arterial phase, you see these nodules here, perinodular enhancement in the arterial phase. When the clips start again, you see very easy, very fast, this perinodular enhancement as we've seen it here. Then we will switch to the portovenous phase. You see it's nearly complete, filled by contrast after 1 minute. There's a little bit contrast is missing in this area. There seems to be some thrombotic changes. But in the late phase, you see there's no change. So this is just a hemangioma. What about this lesion? That's a huge lesion with a diameter around about probably 10 centimeters. So you see also this lesion compressed a couple of vessels from here to here. That's the complete extent of this lesion. This is also a hemangioma because it's only echogenic. So if we inject contrast, we see also this lesion has got perinodal enhancement in the center. There is no contrast uptake in the beginning. Then we will switch to the portal venous phase. You see these nodules are growing there. And late phase, these nodules are growing. So that's a giant hemangioma with a diameter around about 12 centimeters, but the pattern is typical for a giant hemangioma, so there is no need for biopsy in this case. By looking at FNH, you remember these three phases. We have got a hyperenhancing in the arterial phase. The portal venous phase, we've also hyperenhancing, and in the late phase, it's iso or hyperenhancing. Sometimes they have got an unenhanced central scar. This is around about 60% of the FNH. So if we inject contrast, we see very strong from the center to the peripheral, this uptake. It's like a flashlight. Once the contrast arrives, it's lightning. This is a central scar. And remember, there is no washout in this lesion over time. So we see this hypergenic lesion. This hypergenic lesion has some vessels, and we see it already here, inside. If we inject contrast, you see that's the feeding vessel from the center to the peripheral, very, very strong uptake. You see the complete extent of this lesion. This lesion has got a diameter around about 4 centimeters. Then we will switch to the portal venous phase, still hyperenhancing. There's a little bit black spot inside. This is a central scar. Still here in the late phase, central scar inside. But still, if you burst the bubbles and wait again, you still have typical pattern for an FNH. So also in this case, there is no need for biopsy. When we look at this image, most of my colleagues will tell me, oh, that's a clear, very easy lesion which we detect because this patient has got a cirrhotic liver, this patient has got ascites. So if there's nodule in cirrhotic liver, the most common diagnosis will be HCC. By looking at color Doppler and power Doppler, we see also a couple of vessels there. And now the question, is this really an HCC or it might be an FNH? By injecting contrast, we see from the center to the peripheral. So there is a nodule in the cirrhotic liver which shows uptake from the center to the peripheral. There are no chaotic vessel pattern inside. And if we switch to the portal venous phase there, hyperenhancing, and even in the late phase hyperenhancing, so or even here, typical pattern for an FNH, which is not so common in the cirrhotic liver. By looking at adenoma, think about these three phases. It's hyperenhancing, complete, isoenhancing, and also in the late phase, isoenhancing. There is the lesion. So if we inject contrast, most of the time contrast arrives from the peripheral to the center. There's a little bit of rim in the surrounding area here. And if you inject contrast, you see this hyperenhancing. And sometimes adenoma could have a slight washout, but not really a washout, so a little bit less contrast uptake in the late phase in comparison to the surrounding tissue. So we see there's a lesion, it's hyperechogenic lesion. There are some peripheral vessels, but also here some central vessels in this area. By looking at contrast, you see typical that the contrast arrived in the peripheral, not so strong in the center. You see this filling here. You see this kind of rim in the peripheral. Then we switch to the portal venous phase. There's the lesion in the split mode. There's the lesion in the contrast. Then we go in the late phases after 3 minutes. No washout. So this pattern matched pretty good with an adenoma, which also were proven under MRI. So liver cysts are very easy because normally liver cysts have no enhancement. So they should have no enhancement in all three phases. So if you inject contrast, you see this posterior enhancement in the grayscale already. Then you see over time there will be no enhancement. Normally there is no need for using contrast if it's a typical pattern for a liver cyst, but sometimes liver cysts could also show a very complex pattern. For example, this lesion. Is this typical for a liver cyst? Yes or no? Probably you could also switch a coin. It could be everything. By looking at CalDoppler, we couldn't detect any vessels, but there might be some microvessels inside which we could not see by conventional CalDoppler or power Doppler settings. By injecting contrast, we see that there is no uptake inside. You see that's the border of the lesion. There's a second one. Then we switch to the portovenous phase. We still see no uptake inside. And even in the late phase, after 2.5 minutes, no uptake. This is a hemorrhage cyst because this patient also went under biopsy in the past. Focal fatty infiltration, focal fatty sparing is very easy because this is liver with fat and without fat. So this means they have got an iron enhancement in all 3 phases. So this is focal fatty sparing. You see there's a lesion. If you inject contrast, a lesion will have the same contrast uptake like the surrounding tissue. So typical, just adjacent to the gallbladder, we see these focus fatty sparing here, so there is no major vessels inside. By using the split mode, there's a lesion in the contrast setting. You see this lesion has the same uptake like, for example, this area. Then we switch to the portovenous phase, no washout. Even the late phase, no washout. So this diagnosis of this lesion fit pretty good with the focal fatty sparing. Focal fatty infiltration is the same way. We have the focal fatty infiltration in the grayscale. If we inject contrast, we see that this lesion will have got the exact same contrast behavior like the surrounding tissue. So also here, just adjacent to the middle liver vein, which divides the left lobe from the right lobe, there is no major vessels here in this area. Then we inject contrast. You see there's a lesion in contrast. This lesion has got the same contrast uptake like the surrounding tissue. And even if you switch to the later phase, there is no washout, so focal fatty infiltration, very quick case. But keep in mind, look really late, even here in the later phase, no washout. And even in this case, after 2.5 minutes, no washout, there's a lesion in the contrast setting. So it confirms the diagnosis. Don't make a mistake and stop the diagnosis or your examination after 1.5 minutes. So just wait up to the end of the contrast agent. Liver abscess have, depending on the age of the abscess, and rim enhancement, and you see typical this also in the grayscale. So we have got a perinodal enhancement, node central enhancement. Sometimes the septs could have a side contrast uptake. It has got in the portovenous phase either hyper or either enhancing rim. This depends how old or how fresh abscess is. This is a patient which we have known before. So the patient developed this area in the liver. There seems to be some vessels in this area. Also, if we inject contrast, you see the central part doesn't show any uptake, but you see very strong uptake here in this area. This was also confirmed as an abscess in the cirrhotic liver. Even if you look later, you see there is the abscess inside, and even in the late phase, no washout, but hyper-enhancing in the peripheral. When we speak about malignant lesion, we focus on liver mets. So they have got strong arterial enhancement or rim enhancement. The portovenous phase, they're hyper-enhancing, and also in the venous late phase, hyper or non-enhancing. There's our liver mets. So if we inject contrast, strong uptake. And the most time that we will see a washout, which is much faster than a half minute or 40 seconds. So there's the lesion seen. This lesion has got a diameter around about 2 centimeters. The lesion doesn't show major vascularization. There's a couple of vessels just adjacent to this lesion. So you inject contrast, you see a moderate hyper-enhancing of this area. It seems to be also some shunts in this area because in this area the uptake is less. But if you see that's less than a minute, this lesion show a clear washout, and if you wait a little later, clear washout, and you see the complete extent of this lesion. This was confirmed also as a liver mets. This is a very challenging case. So this patient had got an MRI and they described a small hemangioma. Unfortunately, the patient has also cancer in the past. Now we should confirm that this is a hemangioma and nothing else. So we look at this lesion. There's a lesion. It's not typical for hemangioma. It doesn't show major vessels inside. Injecting contrast, we see that this nodule show a rim enhancement. Also here you see some uptake inside. This patient had got pancreas cancer in the past. And if you wait, you still see bubbles enter this lesion, but typically it's rim enhancement here. And if we go later to the portovenous phase, you see clearly this washout, and even in the late phase, clearly washout. So this was a very, very tiny liver mets with a diameter less than 1 centimeter. No hemangioma as reported in the MRI. Shoreline carcinoma have got often in the arterial phase rim enhancement or central hyperenhancing. The portovenous phase and also in the late phase, they're hyperenhancing in comparison to the surrounding tissue. So we see our CCC in this area, so a moderate contrast uptake, but also a much faster washout in comparison to the HCC. Now it's your challenge to see where the lesion. Probably also it will be a challenge. So my suspicion, probably look at this area, might be a lesion. So we inject contrast. There's a lesion with a moderated uptake. Probably there's a good chance also to miss this lesion in the grayscale, even if this lesion has got a diameter around about 2.5 centimeter. And you always see that around about 35 seconds after injection, this lesion should wash up. Also, there's a second one, probably also pretty good to miss it in the grayscale there, this one. If you wait a little bit longer, you see more lesion. There was a lesion. There's another 3 or 4 lesions already in this plane, which we probably could have a good chance to miss it in the grayscale. And this was confirmed also as a CCC. Also here, look at this liver. Did you find the lesion? Probably you say, yeah, there might be a lesion. By color Doppler, also this lesion doesn't show major vascularization. You see there's a lesion, there's a lesion. There it is. There's the one here. The arterial phase. Then we switch to the portovenous phase. You still see there's a washout, there's a washout. So in this small image, we already see at least 1, 2, 3, 4 lesions. And if we wait a little bit longer, still see clearly detected. The smallest one has got a diameter around about less than 0.5 centimeters, a very tiny one. And this lesion has got a diameter around about 1 centimeter. HGC, there are a hyperenhancing, and we have also a chaotic vessel pattern. In the portovenous phase, it's either agenic or in the late phase, it's hyper or non-enhancing area. But sometimes we have to really wait to a long time until we see this washout. So sometimes it takes up to 4 and even 5 minutes. So there's a lesion. It shows a strong uptake with chaotic vessel pattern. And in the late phase, this lesion show a washout. So we see there's a lesion in the right liver lobe. This lesion shows some peripheral vessels, but also some central vessels, as we've seen it here. You see a very, very strong uptake. There's another one. And then we switch to the portovenous phase. It's still hyperenhancing in the portovenous phase after 1.5 minutes after injection. Then we switch to the portovenous phase. That's around about 2.5 minutes after injection, still hyperenhancing. And look here, that's late phase. That's nearly 5.5 minutes. but you still see that this lesion getting a little bit darker in comparison, for example, this area or this area. This was also confirmed as a really rare differentiated HCC in a cirrhotic liver. So in conclusion, what are the recommendations? The other recommendation, CEUS is suggested as a first-line imaging technique for characterization of focal liver lesion which detected under conventional ultrasound. It's also recommended for characterization of focal liver lesion in non-cirrhotic liver in patients with inconclusive findings at CT or MRI. And if CEUS has definitely characterized a benign liver lesion, there is no need to do further investigation or biopsy. It's also very helpful to characterize hepatic abscesses. And there's also a recommendation that CEUS can utilize CT or MRI imaging if it's inconclusive. So with my last slide, I would like to thank you for your attention.